Hi everyone. This is your podcast for somatoform, dissociative, and sexual disorders for Nursing 244. The basis for somatoform disorders is often unclear and complicated. Experts believe that there is a multi-dimensional causal model which encompasses a complex interaction of neurobiologic, psychological, and familial factors. So more about some of these in a little bit. A careful review of the history of the client's physical complaints is essential to rule out any existing medical illness. Nurses should collect data about the lifestyle, emotional status, and relationships of these clients because psychological distress and interpersonal problems often are common. The common mental status findings in somatoform disorders include behavior, mood and affect, thought, process, and content. Your book has an assessment tool, 24.1, Common Mental Status Findings in Somatoform Disorders. And it talks about behavior. And if you want to follow along in your book, you sure can. Behavior, an alarming, crisis-oriented symptom presentation focusing on particular physical concerns, excessive fear, dread, worry, apprehension, or rigid or obsessional thinking, restlessness, diaphoresis, palpitations, shortness of breath, muscle tension. You look at mood and affect. Reports of difficulty concentrating, thinking clearly, completing tasks, or enjoying usual activities. Unemotional affect when describing anguishing symptoms. In conversion disorders, which we'll find a little bit about in a minute, description of situation without any affective display at all, called label indifference. Thought process and content. Thorough knowledge of illnesses or illness associated with specific symptoms. Express concerns about a specific aspect of a physical appearance. Somatoform disorder versus factitious disorder and malingering. Factitious disorder is where clients make up or inflict symptoms. An example is Munchausen syndrome by proxy. Malingering is where clients consciously create or exaggerate false symptoms to avoid work or other responsibilities. When you look at, somatoform disorder, there's a lack of voluntary control versus the voluntary control that you see with factitious or malingering. Some clinicians believe that somatoform disorders provide clients with primary gain. Symptoms block psychological conflict or anxiety from conscious awareness. Secondary gain relieves clients from expected responsibilities and the attention that they receive. Such gains may positively reinforce and help to perpetuate somatic symptoms. There are types of somatoform disorders. Somatization disorder is where clients present with exaggerated, inconsistent, yet complicated medical histories. Undifferentiated somatoform disorder involves persistent, unexplained physical symptoms that last for at least 6 months. Conversion disorder, the primary feature here is loss of voluntary motor or sensory functioning. Hypochondriasis, clients fear that they have a serious disease despite no significant pathology for thinking so. Pain disorder, the classic symptom is the inexplicable presence of physical pain as a major focus in life, and body dysmorphic disorder, preoccupation with an imagined deficit in appearance. Somatoform disorders do not appear to have medical causes, but they do have psychosocial causes that produce physical complaints. In contrast to people with factitious disorder, those with somatoform disorders do not consciously want or purposely produce their symptoms. The two main groups of somatoform disorders are the hysterical somatoform disorders, in which there's an actual change in physical functioning, and preoccupation somatoform disorders, in which people who are healthy become worried mistakenly that there is something physically wrong with them, and they have symptoms for which no underlying organic basis exists, and it's a possible inherited predisposition. Chronic usually begins in the teenage years. Somatization are multiple physical complaints, often chronic, and begin before age 20. Pain, unexplained pain, organically severe and prolonged, that impairs the person socially, occupationally, and functionally, and these folks often have depression with and dependence on addictive substances. Hypochondriasis is where people believe that they have serious diseases. They are preoccupied with, they might believe they have a serious disease, or they might be preoccupied with the fear of contracting a serious disease. Body dysmorphic disorder, serious, chronic, disabling belief that the body is deformed or defective in some way, most common flaws of face and head. And we'll talk about conversion disorders in just a little bit. Here's a little slide, if you will. It shows you factitious disorder versus malingering versus somatoform disorder. So it just kind of helps you separate out the three and what do they mean. And as you can see, under somatoform disorders, we have somatization disorder, conversion disorder, and hypochondriasis. So again, looking at them in an overview and talking about, you can see on the slide it talks about where the chief goal is psychological or primary gain, and where the chief goal is external or secondary gain, and that would be a person that's a malingerer. They get out of responsibilities because of it. Conversion disorder is a loss or change in body function resulting from a psychological conflict. The physical symptoms cannot be explained by any known medical disorder or pathophysiologic mechanism. Clients are unaware of the psychological basis and are therefore unable to control their symptoms. Psychological factors may precipitate, and it usually occurs after a situation that produces extreme psychological stress for the individual. Symptoms appear suddenly. Most resolve within a few days or weeks. About 75% of those who have had it never get it again, but 25% of patients who have had it will experience additional episodes during periods of stress. And what you see manifested: paralysis, seizures, coordination problems, difficulty swallowing, blindness, deafness are just some examples that you see as loss or change in body functioning resulting from the psychological conflict. So again, that's what conversion disorder is. Here's another slide on conversion disorder. As I told you before, it's results from a psychological conflict. Physical symptoms cannot be explained by any medical, voluntary, motor, or sensory functioning. It is suggestive of neurological disease, sometimes called pseudo-neurological. So the event is precipitated by severe trauma. They have neurological symptoms. What does the client get from this disorder? They may have primary or secondary gains. Maybe it enables avoidance or difficult situations or unpleasant activities about which there is anxiety and secondary gains, and they receive attention and support that might not be gotten otherwise. Gets them out of activities as well. Again, the symptoms often appear suddenly, and often the person expresses a relative lack of concern that is out of keeping with the severity of the impairment. This is often a clue. Lack of concern toward the symptoms due to the fact that the anxiety has been relieved by the disorder is called la belle indifférence. Recommended treatments then for somatoform disorders. There is a box in your book, it's called box 24-1, and it is overarching interventions of the multidisciplinary team. And if you want to follow along in your book, these are what the box says. Early screening and diagnoses. Medical or multidisciplinary care coordination. For some reason I can't talk today. Finding meaningful language with which to name the illness that is acceptable to the care provider and client. Regular brief office visits that minimize the client's need unconsciously to develop additional symptoms to meet dependency needs. Management by nursing clinical specialists that includes frequent supportive contacts, reassurance, and monitoring of physical status. Regular health maintenance screenings and appropriate physical examinations to avoid missing any symptoms that may have a medical basis. Normalization of an empathy for the client's distress. Exploration of predisposing factors that create vulnerability to development of a disabling condition. Precipitating factors that trigger illness episodes, and perpetuating factors that serve to make maladaptive illness behaviors stable over time. Safe environment for the client to express feelings. Chronic disease and rehab models that focus primarily on client functioning, and appropriate control of access to medical services. Most of us who have worked emergency room in the past, we talk about our frequent flyers. And these are folks that come in, and I'll give you an example, and I can still see her. Her name was Elizabeth, and she used to drive this kind of old Cadillac, if you will. It was tan, it had a white roof, and Elizabeth, we would see her pull in. You know, the triage person would see Elizabeth pull into the parking lot. The receptionist might see her pull into the parking lot, but the next thing we knew, they were coming back and say, guess who just pulled in the parking lot? Elizabeth. You know, and Elizabeth was one of our frequent flyers. And now I'm not breaching confidentiality because you all wouldn't have a prayer to guess who Elizabeth is, because this was back when I lived in Indiana many years ago. And she would come in, and one night, I kid you not, she came in and she was complaining. Her chief complaint was she had dry skin on her hands. Basically, the triage nurse gave her some little packets of Vaseline, gave her some rubber or disposable gloves, and recommended that she put Vaseline on her hands, put the gloves on, and wear them to bed at night. And that was, she came in with these kinds of complaints all the time. We probably didn't recognize that she had a mental illness. We just called her a frequent flyer. We weren't very, very sympathetic, as you can see. Individual, to look at the slide then, some treatments. How do we accomplish these overarching interventions, and how do we accomplish goals for our folks with somatoform disorder? Individual and group psychotherapy, psychopharmacologic agents, the SSRIs are a recommended first line for these folks. Biofeedback, that way they can control their physical symptoms. Meditation, relaxation. Some activities to assist clients with adaptation then. Developing trust and establishing a therapeutic relationship. Demonstrating genuine concern and caring with supportive interactions. Assisting clients to improve physical health and adapt to stress. Enhancing self-knowledge, and helping clients consider alternatives for coping other than through physical symptoms and illness. Again, assessment parameters for somatoform disorders. We're going to look at mental status, physical examination, and social assessment. And nursing diagnoses then for clients with somatoform disorders focus on identifying the causes of dysfunctional coping and issues related to the family and psychosocial interactions. Some possible nursing interventions for somatoform disorder. have to do with anxiety reduction, body image enhancement, calming technique, cognitive restructuring, coping enhancement, emotional support, security enhancement, self-awareness, and self-esteem enhancement. Dissociative disorders. These are mental illnesses that involve disruptions or breakdown of memory, consciousness, or awareness, identity, and or perception. And these folks have two or more distinct personalities. An alteration in conscious awareness of behavior, affect, thoughts, and memories. It's characterized by an alteration in identity, often precipitated by a traumatic event like disaster, rape, war. Regardless of the type of dissociative disorder, all sufferers at times demonstrate behavior totally different from usual behavior. There are some types of dissociative disorders. We have dissociative amnesia, dissociative fugue, dissociative identity disorder, and depersonalization disorder. Amnesia is blocked memory. They can't remember personal information, and it's beyond forgetfulness. It's not like simple amnesia with a brain injury or disease. Here, memories are buried. In fugue, these are your travelers. Sudden, unexpected travel away from home or work with the inability to recall the past, confusion about their identity, or assumption of a new identity. They can't remember the past, they are unaware that they have forgotten, and they have confusion. Both of these, dissociative amnesia and dissociative fugue, are associated with stress or traumatic event. Sometimes fugue is blamed on alcohol consumption. The goal here is to restore memory and deal with the stress that triggered. So on the next slide we'll talk a little bit about dissociative identity disorder. This is your classic multiple personality disorder dominated by at least two or more personalities. The single individual evidences two or more distinct personalities, at least two personalities that routinely take control of behavior, and is associated with memory loss. The origin of disorder is severe sadistic, often sexual child abuse. Treatment is challenging and requires the skill of an experienced therapist. Does not always clear up. Signs and symptoms may come and go, and it makes for a very chaotic life. The goal is to integrate the personalities, although it's not always possible to integrate them. There is hope for at least harmonious interaction between the personalities so the person can function. Drug treatment, we often use meds for depression, but it really does not help the disorder at all. Therapy is often long and painful because, again, oftentimes the origin is a severe sadistic experience, perhaps severe sadistic sexual child abuse. So therapy is long and painful, recommended 2 or more sessions a week for 3 to 6 years. They have found some help with hypnosis, and of all disorders, this one has a very poor outcome generally. You can see the little cartoon. Please be reasonable. You have 16 distinct personalities, and I'm only billing 3 of them. So kind of a funny little cartoon. Question. A client tells a nurse that he was found traveling in a different state without being able to recall the event. What type of dissociative disorder would be suspected in this case? And just to explain the bottom one, that's DID, that's the dissociative identity disorder. So in this case, I'm hoping that you chose C, dissociative fugue. Depersonalization disorder, we didn't really talk about that, but I had talked about depersonalization and derealization before. And depersonalization is kind of that out-of-body experience, if you will. And I don't have a lot of slides on that or anything. It's not real common. You don't see a lot of it. Your book will have a little bit more of a description. Comorbidities of dissociative disorder. Addictive behaviors, eating disorders, depression, anxiety. Severe depression is present in over 70% of these people, and hence the use of antidepressants. Panic attacks are common, and at least 90% of these clients present with psychotic symptoms. Remember the two dimensions of psychosis: hallucinations and delusions. So interventions for clients with dissociative disorders: talking therapy, hypnosis, cognitive behavioral interventions, group therapy, psychopharmacology, art therapy, just to name a few. And then on to sexual disorders. There are types of sexual disorders: desire issues like hypoactive sexual desire disorder, sexual aversion disorder. There are arousal disorders: female sexual arousal disorder, male erectile dysfunction, for instance. There's orgasmic disorders. There's pain disorders. If you had OB already, you may have learned a term called dyspareunia, where a person has painful sexual intercourse. Paraphilias are sexual expressions characterized by recurrent, intense, sexually arousing fantasies, sexual urges or behaviors generally involving 1. non-human objects, 2. suffering or humiliation of oneself or one's partner, or 3. children or other non-consenting persons. Gender identity disorders have to do with strong identification with the opposite sex and persistent discomfort with one's assigned sex. People who identify with and live as if they are of the opposite sex are transsexuals. Transvestites are those who cross-dress for sexual arousal. The last one, compulsive sexual behavior, is on the next slide. Characteristics of those with compulsive sexual behaviors include recurrent, intense, sexually arousing fantasies, sexual urges or behaviors for at least 6 months that involve compulsive cruising and multiple sex partners, compulsive fixation on an unobtainable partner, compulsive masturbation, multiple love relationships, and compulsive sexuality in a relationship. Classifications of sexual disorders: they can be lifelong or acquired, generalized or situational, psychological or combined, and some strategies for treatment. And what I want to point out here is referral to appropriate professional is the key to treatment. I think us as nurses, we can educate the patient on what kind of treatments exist out there, what kind of specialists there are. But I don't know about you guys, I am really not in any position to counsel someone with some of these sexual issues or problems or diagnoses. I just don't know enough about them. You know, I can reasonably talk a little bit about female sexual arousal disorder and male erectile dysfunction, a little bit. I even have an understanding of sexual aversion disorder or hypoactive sexual disorder. But I'll tell you what, past that, I don't have a whole lot of knowledge about them. So I would refer them to the appropriate professional. Assessment, some of the things that, strategies for treatment though, assessment of the couple affected by the sexual disorder. Oftentimes, and it's couples therapy, because what happens is perhaps each partner is blaming the other. You know, they're blaming the other for their maybe lack of sexual desire or sexual response, or perhaps painful intercourse. And so when you do couples therapy, it actually helps to pinpoint, and oftentimes it's really on the part of both of the people that make up the couple, and so they can work within that. Medication management to improve sexual functioning or provide symptom management. Some postmenopausal women, you've probably all seen the ads for some of the creams and such for postmenopausal women when they get the thinning of their vaginal wall and get a lot of pain with sexual intercourse. Then there are creams and such out there that kind of help restore that vaginal wall a little bit, thicken it up a little bit, more lubrication and so on. And so there's different medication managements, and you've all heard of, medications for erectile dysfunction, of course. Education regarding normal sexual functioning, training in couple communication and sexual skills, and couples counseling to address other issues that may exist in the couple's relationship, maybe some resentment from a previous affair or whatever that is really blocking that couple's relationship and their ability to express their love in an intimate way to each other. When we are in class, we will actually look at an assessment sheet, if you will, for both male and female to assess sexual functioning and for sexual problems. And that is the end of this podcast.